As we normally do, we're getting into a Healthy Friday conversation this morning, necessary for us to have, and we're looking at one issue that affects many, many people, not just because of the patient and what they go through, but families across board. We're talking this morning around the issue of postpartum hemorrhage. Joining us in the studio this morning, Dr. Charles Okumu is an obstetrician gynecologist, and Jane Mbaluka is the National Treasurer of the Midwives Association of Kenya. Good morning to you both.
Good morning.
Karibu sana.
Asante.
Great to have you in the hot seats of the Situation Room this morning. It is a hot topic that we're going to be talking about, and we really want to open it up and really get into the nitty-gritty of it. Many, a woman suffers severe health conditions because of this, and unfortunately death in some cases. And even as we do, we'd really like to get into that. So we're very happy that you've been able to join us to do that today. Before we do, Dennis is going to share a proverb. He'll tell you where he's sharing it from, and we'd like to get your interpretation of the same, both of you. Is that all right?
So the proverb today comes from Kenya, a beautiful country, but the proverb comes from a specific community, the Kamba community, who have for a very long time been known, according to history books, are long-distance traders. And when it gets towards the mango season, you're told to get yourself a Kamba friend, because the sumptuousness that comes from that area is really beautiful. But even now, agriculture is still a huge factor in Ukambani, and now we know counties like Makueni are into cereals. If you want, they call it ndengu, or even lentils. Makueni is getting that to you, as well as just restoring the ecosystem. Climate change is a factor, and everything is being done so that sand harvesting is reduced so that the ecosystem can regenerate. But let's go to our proverb. A man who asks for direction never gets lost. A man who asks for direction never gets lost. Ladies, go first.
Yeah, thank you so much. I think it's very light that a man asking for direction never get lost. It shows that you can never know everything. You need to coexist with others. You need to teamwork with others. And that guidance will show you the perfect way. Yes.
Well put, Dr. How would you interpret that?
I agree with that. Yeah, indeed. Ask. Knowledge is vibrant, and I can't sit here and know everything. If ask. In not just in direction, in every line, even professional lines, we learn all the time, and we learn by asking colleagues in that line. Yeah.
Fantastic. We learn by asking. And we're talking about a health condition today, or a situation that gets a lot of people affected, not just the woman who goes through this during childbirth, but then you can imagine if a woman goes through postpartum hemorrhage and loses her life. There's a newborn baby, if they've made it, who has to deal without a mother. There is a partner, in this case could be a husband, who then has to deal without a wife. Those are some of the things that we're looking into this morning. But even as we start, Dr. Okumu, we have heard these two professions go hand in hand a lot. Usually you'll find that an obstetrician and a gynecologist are one and the same person, but they're different. Can you just do a differentiator for us in terms of the differences between the two, and how do they often go together?
Obstetrics deals with pregnancy only.
Okay.
Gynecology deals with everything.
Okay.
So what we are discussing today, I don't know if you have introduced it already, postpartum hemorrhage, that's obstetrics.
Okay.
Yeah, so pregnancy and delivery is obstetrics.
Okay.
Other things, all the other things are gynecology. Yeah.
Okay, and so you often have a doctor who is versed in both.
Yes, in the British system we are trained in both.
Okay.
But in countries like the United States, you can just be an obstetrician.
Okay.
That's all I know. Nothing about, I have zero knowledge of gynecology, but I'm an obstetrician.
Okay.
Or just a gynecologist. I have nothing to do with the deliveries. I don't want, especially, and in the United States, it's important because of litigation.
Okay.
Yes, I don't want to deal with babies where you are suing me, the baby scored badly, the baby is not smart, So you say, especially men, we don't want obstetrics.
Of course
we do
not.
gynecology
Only.
Yeah.
Okay.
Yeah.
And then, what does a midwife do, or who is a midwife? And are midwives only women? We say midwife, so it must be a woman. Just like we used to think that nurses are only women. But please do tell us.
Thank you so much for that. I want just to clarify that it is not only women who are midwives. A midwife is somebody who has undergone training and had been certified by a legislature. For this case in Kenya, we have the Nursing Council of Kenya. And when we look at, we find it can be a man, it can be a woman, that is a lady or a gentleman. And you need to be certified. And that is why we call them the skilled. The skilled deliveries are done by the skilled, where we have moved away from the traditional birth attendants. So that is somebody who is trained. In Kenya, we have a combined, where we have the nurses, midwives, whereby they are trained one course. You go for a degree course where you have been trained for maybe for the general nursing and for midwifery. And we also have the trained midwives. You just go for the course and you are a midwife.
So what does a midwife do?
The midwife takes care for the mothers, of course, during antenatal, during delivery, and postpartum.
Okay.
And postnatal period.
Okay.
That of course you monitor the mothers during that time when they are pregnant, from the time of conception, and we also have preconception. Okay. Where they come and they want to conceive, and then you work with them. A midwife should work with that mother from the time she's confirmed, even before when she want to get that baby, the time she conceives. Remember, we also do the family planning. So when you also get the baby, you come to the labor ward, you'll find us there. And then after that, we'll follow you up with the baby, of course, up to 1 year and even more. And even come to the communities. So that is exactly what a midwife does.
Okay.
Yes.
And do doctors and midwives work together? Gynecologists, obstetricians, midwives work together?
Absolutely.
Okay.
Absolutely. We work together. A doctor, the obstetrician, will review the patient every so often and say, now she's X centimeters dilated, the heartbeat is okay, the drainage of the water, the liquor is okay, but it is sister who is there on a continuous basis. And that's the sister who will notice that no, the heartbeat is now no longer okay, and will call the obstetrician to review. And depending on how far along the patient is, we can say, okay, this we must now carry out a cesarean section, or we are almost there. Let us observe and let us deliver normally. Okay. So they work hand in hand. In fact, the midwife is closer to the patient than the obstetrician, because she is there monitoring every single change in the mother and in the baby.
Okay.
Yeah.
So, I mean, it's good to get that foundation so that we know where we are going and who's doing what. Now, when we talk about postpartum hemorrhage, what exactly is that, Dr.
This is the most dangerous of all the diseases that are killing mothers. When we say maternal mortality, is postpartum hemorrhage and others. Postpartum hemorrhage is the worst, in my opinion, because postpartum hemorrhage is bleeding after the patient has given birth, which means it is happening in the hands of the caregiver. And this caregiver is anybody who is at that particular point monitoring that patient, which includes our traditional birth attendants at home. And that's what makes it extremely dangerous, because right now, the number of mothers who are still delivering at home is at least 40%. The next demographic and health survey will tell us exactly, but it's in that region.
Of all the babies that are born
in this country,
in Kenya, 40% are
delivered by TBS.
Wow.
Okay, so postpartum hemorrhage is bleeding after the baby has come out. The reason I'm emphasizing that is that it is impossible for our peripheral health workers, like the public, they're called public what? The mashinani people, kabisa, these ones who are doing COVID, they cannot help us. They cannot give any knowledge to the prospective mother, because again, up to almost 50%, it just happens. We don't have a reason, so we can't say, Mama, you look like you are going to have PPH. Therefore, start doing this and start doing the other. This is something that happens suddenly when the mother has delivered.
So essentially, you're saying community health workers or community health volunteers cannot be trained on this. Meanwhile, you have a pretty large percentage of women who are giving birth where community health workers are stationed that would essentially be able to help them.
Yeah, because you cannot, it happens after delivery. So even an expert, even an obstetrician, even a midwife is only in very small cases. When we go into the various courses, there are things you can say, you are high risk. You are high risk for postpartum hemorrhage. So you start going to this facility, and the facility I'm talking about in our hierarchy of level 1, 2, 3, 4, 5 must be a level where we are able to do cesarean section. Anytime we are in a situation where we cannot take a patient to theater, even if it's a government facility with the trained clinical personnel, we are living in dangerous times, because it will happen now. And this patient has retained placenta, which is one of the causes of PPH, and you need to take to theater and remove it, and you can't.
So, with what you've said, it is really important for a patient, for mothers, to be with a midwife from the very beginning all the way to the end. But in most instances, you find the only time a mother would come into contact with a midwife is pretty much at the last stage of it, which then cuts that. If you look at the importance of starting from the beginning to the end, but if I'm just meeting you at the end, that means just so that you deliver me and I'm done with you. But how then important would it be for one to have a midwife from the beginning, such that when such happens, when hemorrhage starts, my midwife is close to me and I can reach them faster, as opposed to just at the hospital?
Thank you so much. Maybe I would also want to add of what Dr. Charles has said about the PPH. It is good to know that we have PPH is blood loss, which when you give normal delivery, is more than 500. If it's more than 500 in normal delivery, that is termed as PPH. And if you do a cesarean section and it's over 1,000, is also termed as PPH. But any amount that causes hemodynamics or changes the state of the mother is referred as PPH or postpartum hemorrhage, even if it's 200, because some mothers will come with very low hemoglobin level. Maybe they just came and maybe they never even went for a antenatal profile. So to come back to your question, and maybe it is very important to work with a midwife, and that is where we would focus in future, where we would have enough midwives, because now as we talk, the number is still very low. So if we have enough midwives, we would be able to work with those mothers, and that is how you identify. Ideally, you're supposed to identify a midwife who can even call, who is a call away from you, so that in case of anything, you will have problem solved. So at the same time, when we have enough, we have many challenges, and maybe that is why you cannot to access to the facility. Socioeconomic status may even make this mother come only one antenatal profile, whereby the WHO recommends 8 of them. So this is one thing we would want in the future, and that is what we would aim, where we will have enough midwives to cater for our mothers, which could be 1-on-1 or 1-on-5. As we look now, the ratio for one midwife to the population, it is really big between, and we need to reduce the gap.
Jane,
Yes.
Dr.
Thank you.
Harry talked about the fact that with a lot of people who are giving birth at the hands of traditional birth attendants, that in the case of hemorrhage, maybe the placenta has not been birthed. That's an example of what would cause this, right? And then you need surgery. So are we saying that if you need surgery to then relieve that situation, if surgery doesn't happen, are these women dying?
Let me come back to that. Thank you so much. One, there are many causes for postpartum hemorrhage. And normally we talk about the 40s. The 40s, we talk of the tone, we talk of trauma, we talk of throbbing, we talk of tears. And when we talk of, tissues. When we talk of tissues is when we talk of the retained placenta. And unfortunately, maybe some mothers will deliver before they come to the hospital. And of course, our community health promoters, they are not trained and they are not certified to conduct any deliveries or to assist the mothers to deliver. The traditional birth attendant, you'll accept that in some areas where they are very remote, they might still be there, but we are trying to encourage them to bring the mothers to the hospital instead of assisting them to deliver. In that case, this mother who have a retained placenta, if they are in the hospital, we will be able to support this mother. And one, immediately a mother delivers is supposed to be given drugs which we call uterotonics, which will facilitate the contractions of the uterus to be able to remove the placenta now. And of course that we call it the AMSTIL, the active management of that stage of labor. The community health person will not be aware of this. And of course, the active management, of course, you'll give uterotonics, you do the uterine massage, and you assist in delivery by contracting the uterus, and then you'll be able to deliver the placenta. So for the traditional birth attendant, they might just wait for it to come out.
Well, okay.
And, yes.
That's interesting that you say
and
that.
also you also need the uterotonics. Uterotonics is the drugs to assist in the contractions of the uterus.
Okay.
Thank you.
And you see, this is at the point where now I've worked with the midwife
yeah,
throughout,
perfect.
and then now there is the OBGYN who
Yes.
also is part of this process to the very end. So
Yes.
Dr. now here is a question where, when you talk about the situation with all the 40s that we were talking about, there is the need for OBGYNs to equally just be, if not a call away, to be closer to the patient and also to be part of the process. But you also find that most of mothers as well just come to contact with OBGYN towards the end, and one would say this could be due to economic situation in the country and whatnot. But then, just how critical are OBGYNs through this entire process?
In terms of managing PPH, the obstetrician and the midwife do the same thing. We know the 40s. So the tone sister, the midwife will manage as well as I will. Trauma and tissue. Trauma means we have torn something. We have torn the cervix, or it has gone up to the uterus. That needs theater. In our country, we have not trained midwives to go to theater. In some African countries, they carry out cesarean section very, very well. These are routine operations. So maybe we need to turn and go there. Tissue is placenta. She can use the drugs that we have enumerated and be able to manually deliver the placenta. So that can be managed. Something like thrombin, that is a family history of bleeding abnormality. That is the only one that can be picked from the history. If even those the peripheral workers, in taking history of somebody who was delivered before, they can pick up that she really bled, and the doctor said there is an abnormality with the blood. Her clotting system has a problem. That one can be picked up and be referred in good time. But something like trauma, the cervix tears during delivery. You didn't know that. You couldn't advise the mother on anything. You couldn't even advise the clinician on anything. This is something that has happened now. Torn means the uterus has refused to contract. Again, sister has given you the drugs that we use. Again, they can be used by myself and the midwife. So basically, we are able to manage as long as this patient has delivered in a clinical setup that has sufficient sophistication to be able to do routine operative interventions. We do the same thing and we will be able to help the patient.
Now, we also have heard about transfusion, which is the replacement of blood. Transfusion services, when applied, do they assist then to stop the hemorrhage and the mother can then get back on into normal condition, Dr. Harry?
They are crucial. The transfusion services are crucial. And that's why I say the facility at which the mother is delivering must be sufficiently sophisticated to be able to do that. Because even if you are unable, there are no theater facilities and the patient needs theater. For example, in the worst case scenario, the patient has a ruptured uterus. Because of obstructed labor, she labored for too long, the baby couldn't come out, the uterus has ruptured. That's one of the most desperate situations. So you need to start a transfusion immediately, even as you are transferring the patient to a more sophisticated area, facility where she's going to go to theater, in many instances, to just remove the uterus. Because once you bleed, sister did say about the 500 cc's. 500 cc's is a very small amount of blood. And the worst thing is that once you go beyond 500 cc's, you go into something we call disseminated intravenous coagulation, DIC, where now the blood does not clot.
Okay.
So even while you are now operating, everywhere you cut, the patient continues to bleed. So you need to replace that blood, and transfusion can start in a more peripheral facility that does not have theater services. So yes, blood is crucial. In fact, it's pivotal in the management of PPH, postpartum hemorrhage, which is bleeding after the mother has already delivered. Yeah.
Sorry, there's a question here, because every time we think about bleeding, we think about that there's a cut or that there's a tear or there's a wound, and that's what something is bleeding from. Sister talked about tears, there could be obstruction, that would be the source of the bleed. But is there a source? Is there a source of this bleed? Maybe some things have moved around. Is there a tear? Is there a cut? What happens? I guess both of you can.
Okay. Sister talked about the 4 T's.
Yes.
When we say torn, it means the uterus has failed to contract.
Okay.
Sister talked about oxytocin drug that once we give, the uterus contracts, and then we are okay. Even if we are worried about the bleeding, we are able to manage. Okay, she has bled beyond 500 cc's, she has had PPH, but we have corrected it. That is torn. The uterus has not contracted. Trauma is when we have a tear.
Okay.
That's a tear, and this tear has happened during delivery. Maybe the mother pushed before the cervix was fully dilated. So we have now a tear. That's trauma. Tissue is when the placenta has failed to come out. Placenta has, and again, we couldn't predict. We have delivered nicely. We are now waiting for the placenta. It is not coming out. That is tissue. The thrombin is the only one that we can predict, because the mother will have a history that in the last pregnancy she bled a lot, and the doctor said that she has a bleeding problem. So yes, that tear will happen during that delivery. It was not there. It has not been caused to us. The baby was a little bit too big. The mother pushed a little bit prematurely, and we see this a lot. We are telling the mama, bado, breathe in and out, bado. The mother just pushes.
So at that time when you're saying that, there's a reason you're saying bado or wait.
Yes, because we are not fully dilated.
All right.
We are not fully dilated.
Okay.
But the mother with those contractions,
It's painful,
especially the people who are pregnant for the first time, the ones we call the primigravida, every contraction is a push.
Yes.
And you are not able to control that. Then you get a tear.
Yeah.
But the tone is people who have delivered previously. The uterus does not contract as efficiently as it should. Then we go into that bleeding.
So what do you do, Jane? I'm sorry, Dennis.
Yes.
So at that point, when that is happening, and you can see that there's a tear, what do you do?
I think having mother bleeding is the most devastating and most scaring situation for the mother, for the midwife, and for the obstetrician, because blood loss you'll definitely lose. So what do you do? One, we have there is what we call emotive. Emotive bundle is what we are using now as skills to manage BPH. E stands for early detection. Early detection. So when you notice that bleeding you're talking about, you are supposed to call for help. Of course, if a mother is bleeding because the placenta is not out, you should make sure it is out. If they are because of those tears, there is you had given what we call episiotomy, and it's bleeding a lot, should be repaired. If there is a fico tear, of course it will be repaired, and this has to be repaired in theater by the obstetrician. And so one, you call the emotive, you have to check what is, you have to detect early. So immediately you realize the mother is bleeding, what do? You have to alert even the ones we are calling the blood bank, that you may need blood. So, and then you also have if the uterus has not contracted, you need to fast track this. You give the ultratonics, where we have the oxytocin, the hydroxybutyrin. You give that to make sure the uterus contracts, and then you replace the fluid. Of course, that is the motive now. IV is to replace the fluid, of course, and then you have to excavate. If this mother continues, like what we are saying, if there is a cervical tear, I may not do it repair it in the maternity as a midwife. I'll need the gynecologist maybe to take this patient to theater, and maybe this patient may be sedated, of course, so that they can repair what is. You can also have another tear, which could also be the uterine has ruptured already, and there has to go to theater and maybe for repair or removal of the uterus. So that is what ideally what happens when the postpartum hemorrhage. You need to act fast. You need to act fast, and you need to have teamwork. Because if you have to replace the blood, you have to need to the lab people have to be ready, that you have to have the sample, and it has to be prepared maybe in the next 30 minutes that you're replacing this. The gynecologist also has to be there, the anesthetist has to be there. So it is a teamwork, and it has to move fast so that we can save this mother. I remember one case scenario. It could have been the worst and the best case scenario I ever had, of a colleague who got the PPH maybe the second day, not even the first day, and that is called the secondary PPH. After 24 hours, it is a primary. Before 24 hours is primary PPH, secondary PPH. The worst case scenario is when a colleague called me and said, "Jane, I'm dying." Because she had gone home and she was already bleeding, and so we had to pick her. She was in the hospital, and then we have to mobilize. The first thing, of course, you need to replace the blood, and of course, before you do that, you shout for help. Shouting for help is where I'll call my senior. I'll call my senior most, even if it's also a midwife who is around me, who is also senior. I'll call them to come and assist. So that is, you shout for help first. You'll of course do that replacement for blood. You'll get samples. So for this case scenario, we had to get samples. It could not stop. We had to put 3 pints of blood to this lady, and unfortunately, it could not stop. So we had the gynecologist had to take to theater, and the theater we had to call what you put we call uterine balloon tamponade, where we put like a balloon to put pressure to the places where the bleeding is happening. So you put pressure, and we had to refer this this lady to the next level. And by the end of the day, she got 8 pints of blood. And you can see how it was devastating, because we were worried that that even some of the colleagues had to donate, because where we transferred there was no blood. So it was the best and the worst and the best case scenario, because by the end of the day she survived. But you imagine having 8 pints of blood, and if you are, as you are asking whether it is very important, it's very crucial, because if you don't have that, if we didn't have that, we would not be talking of a live person today. Yes.
So you look at all these, and then the next question is, what would be the risk factors that do exist? And I will just go through some. Let's talk about prolonged or rapid labor. We have over-distended uterus, that is either twins or a large baby. And then we have previous PPH, Dr. now says here, is that would now come through the history, and retained placenta, preeclampsia and eclampsia, and uterine fibroids. So now here's a question where, with all these in mind, especially where we know either you're having twins or a big baby, this is considered to be a risk factor. Hence, starting to prepare early just in case it happens, you know. So this would be knowing the blood group, perhaps even asking in advance if people would go donate blood, so we are prepared. Are these some of just the measures that should be taken before, just to be ready? Not necessarily saying that we are speaking doom, but just getting ready.
That's why Jen said she has to work with the patient. In fact, it's not even a patient, because pregnancy is not an illness. It should not even be killing anybody with the client, because some of those risk factors are noticeable. We will have noticed that this is triple pregnancy. So that will overextend the uterus. It will interfere with the tone. We will already know that if the clinician is at a place without those remedial factors that we have mentioned, then you will deliver at place X only. Okay? Things like uterine fibroids. Uterine fibroid is a stone, so it interferes with the elasticity of the uterus. So once the baby has been pushed out, either normally, so the uterus cannot contract. The bleeding vessels are just looking at you, and the oxytocics that Jen is talking about will not work very well. So we'll have said, because of this uterine fibroids, you'll deliver at place X. Because of your history of previous bleeding, you'll deliver at place X. Because this baby looks clinically big for this small girl, you will go to deliver at place X. So that we are talking about the uterine rupture. All those, because, you know, now something like retained placenta just ambushes us like that. Na imekataa, imekwama. And but if some of the causes of retained placenta are things we call epacrita and acrita, where the placenta is abnormally buried into the uterine wall. Now that, in a sophisticated situation, we will have known sometimes from the ultrasound, just routine ultrasound. All these are things that should be routine. We should not wait for the patient to feel ill from something for us to do them. So yes, if those factors, if the client is moving with the midwife, we will know some of them. Okay, we'll know tone, we will not know trauma, but you can also know trauma. That's why we are saying this baby is big. You must deliver in place X. Just clinically, your pelvis is small compared with this head, so you must deliver in place X. So working with the midwife is extremely important. And let me just put something that Jen said before we forget. Another important reason why the patient should work with the midwife, Jen did say that even 200 cc's of blood loss can be PPH, because if we don't know that this mother's hemoglobin is 7, even 50 cc's will be PPH. So we'll have noticed this patient is anemic in pregnancy, we'll have boosted the blood level back to normal. You know, so this 500 cc's is assuming that the HB is normal. If the HB is low, 50 cc's will be a crisis.
Okay.
Maybe to add. Maybe to add on something on the risk factors that you have come up with. It is true the risk factors are there. But remember in the back that every mother, it has a risk of getting PPH. But there is what is the strategies we are having in place. One of them in the guidelines is to have a PPH kit in every facility or in every delivery room. That PPH kit is where we have every crucial thing you need to manage a one mother who develops PPH. It has the ultrasonics, it has all the fluids you need, it has the bottles for taking samples that you will not run looking for them within there. So one of the recommendation is on the guidelines in the management of PPH is to have a PPH kit in every delivery room. And after the mother who gets PPH, you replenish that the next mother will not lack anything. Yes.
Okay. Let's look at the footprint around the country when we talk about postpartum hemorrhage. And that's general information and knowledge for us to understand. Are we seeing that cases of postpartum hemorrhage can actually be handled, or are we losing these mothers?
I did talk about the 40%.
Yes.
The people who are delivering at home under traditional birth attendants, those ones we are losing.
They're dying.
We are losing because we have hubs that the traditional birth attendants use to contain this bleeding. And in fact, even oxytocin was manufactured after a Muzungu discovered some plants in the coast that work, that the traditional birth attendants use. And they took it out there and they manufactured some of the oxytocin drugs for us. So, excuse me. Yeah, so the
drugs.
The drugs that we are using are available, but to those birth attendants, which takes me back to what we did as a government in the mid-80s. At that time, the government integrated traditional birth attendants into the healthcare system, and they taught them to pick those risk factors. Small girls with big baby, mother with the pelvic disability, all this swelling that leads to the hypertensive disease of pregnancy that we are talking about, and send them to the facilities. And it worked very well for a while, but it became disastrous because now traditional birth attendants decided that they have been trained, so they are doctors. So they started to handle very dangerous cases. So the program collapsed. But if we had surveyed it and evaluated it and supervised it properly, we would have reduced the overall maternal mortality, not just due to PPH, but due to all the risk factors. So yes, to answer you specifically, the mothers that we are delivering under traditional birth attendants and they are getting PPH are dying.
Goodness.
Yes.
Maybe to add something on what Dr. Charles has said, there is also the strategy by the ministry, of course, to reduce this burden. This is not only a priority in Kenya, it's a worldwide priority for taking care of PPH. One is training the healthcare workers with what we call EMOC trainings, where we have them trained on the basics of what is supposed to be done. And this is where the kit comes in. And we know ministry is doing that. However, we still have gaps. The gaps is where we talk of the socioeconomic status, and of course we also have the infrastructure. Those are the challenges we also get. So despite that, we are saving mothers, but we still have mothers we are still losing. Because as we still say, PPH account for almost 70% of the mothers who die after in relation to giving birth. So this is very crucial, and we really need to put more and save our mothers from not only even on PPH, even all maternal deaths. Remember, losing a mother is like losing an entire family, because normally those babies who are left, 35%, they don't even celebrate their first birthday. Because of course, a baby with a mother will breastfeed for 6 months. This baby who is left might not they might not even afford the commercial milk. They might not even afford, and the milk which we normally make for us, the one we use, the young babies may not digest.
I hear you.
So that is one challenge. So we still have a lot of strategy to put to save the next mother from dying. Yeah.
Dr. Okumu, then if we are saying that these births that take place under the hands of traditional birth attendants that then result in PPH, we are saying they are dying. Does that then say that in sophisticated facilities, and we're not even saying that sophisticated, whereby you have transfusion services, whereby you have at the very least some kind of provision for surgical procedures to take place, are we saying that cases of PPH in these facilities then don't result in death?
In many instances, they don't result in death. Unless if we have a clinician and you have a theater and you have a blood bank, if a mother who is already here, if a mother comes in, that's a different matter, because it depends on what state she's in. It might be in DIC, where I was saying that even if you put a stitch, that stitch bleeds. In a case that has that, if a mother dies there, that's now professional negligence. That mother should not die.
With all those facilities.
Blood, qualified clinicians, and theater. Nobody should die from PPH. Yeah.
A good note to hear and a good note to end on. This has been most educative for us to then be able to understand what really happens in these cases. Thank you so much, both of you, for joining us. Jane Mbaluka is the National Treasurer of the Kenya Midwives Association. Dr. Charles Okumu is an obstetrician gynecologist, have been here for our Healthy Friday conversation around postpartum hemorrhage. Thank you so much for being here this morning. Really appreciate you both.
Asante sana.
This is the Situation Room, the only way to start your day.